It's a great opportunity to start, and I'll be happy to help you and getting this experience for good results. So you can count on me. Of course, we need to begin it very slowly. So first of all, I would like to thank the organizers for inviting me. It's a great pleasure to be here. It's an honor, my first time here. And I hope my lectures will help you to understand what is the BPH disease.
We please fix this?
And how we, as physicians and interventional radiologists, we should work in collaborations with urologists to develop a successful department and get good results. I think it's here, let's see. That's perfect. I had some problems with videos, that's why I'm using my own laptop, but now I think everything is okay. So I'm going to talk about technique. I have two talks. The first one will be about technique and results. Here are my disclosures. And the technique that we have previously described since 2008. In 2007, we did our preclinical studies in dogs in the United States, and after that we moved in 2008 to the first 2 patients that we performed prostate embolization that we have published at that time. So since that time, we have changed a little bit our technique trying to get better results. And the technique previously published last year it was published in CVIR, the European Interventional Radiology Society journal. And what is it about? It was said by my previous speaker concerning the Foley Technique. The Foley Technique is very, very useful. Patients without Foley catheter, we place the Foley catheter immediately before the procedure. We fill the balloon, the Foley balloon, with a contrast media and do the procedure and remove the Foley catheter immediately after the procedure. So patients do not go home with the Foley catheter. But patients that have the Foley catheter, we just fill with 20 to 30% of contrast medium for some important reasons. It is important for the proviso that was said. It's very important to use it as a reference when we are using cone beam CT. And it is very important to show the relationship of the proviso arteries using ipsilateral oblique view ranging from 20 to 50 degrees that we can identify all these arteries, the pudendal artery, the rectal, the middle rectal artery, the obturator that has always this shape here, and the inferior vesicle, superior vesicle that's here, and the relationship with the Foley balloon. But remember, use the oblique view. Here you see this video. There's a classic anatomy of the internal iliac artery. The first one is the umbilical and the superior vesical artery. Here we have this shape that is the obturator. This is the middle rectal artery. It's internal pudendal artery. So we need to see here, the balloon is here, the catheter of the balloon is here, and we need to look at this position immediately below the balloon to see what is the artery that is coming here. And this is the artery. That's the inferior vesical artery. And what is the reason that we call inferior vesical artery? It comes from urology view. So they identify during surgery, the upper one is the superior and the lower one is the inferior. So our technique, we need to use the ipsilateral and posterior anterior views. We need to look for the inferior vesical arteries, try to identify all arteries, use a microcatheter for every case to avoid complications and to get good results and to have very distal positioning of the microcatheter into the gland. We have to get into the gland. We need to look for some shunts and avoid complications. You see during my second talk today that we can have some serious complications, and we need to put the catheter very distal, past the bladder and the rectal branch. Our complications are mostly related to the bladder and rectal, and we need to use these both incidents. Posterior anterior is very useful for anatomy of the prostate. You see, and ipsilateral to identify collaterals. So let's confirm what I've said. Posterior anterior, we see here the balloon, arteries, and here are arteries that are feeding the prostate. So we can see, using the posterior anterior perspective, quite well the prostate that is here. But what is this? And what is this? So what we need to do is to move to the ipsilateral oblique view. And see here, this posterior branch, and this branch, pay attention here. These branches are not going to the prostate. So if we perform a proximal embolization from this position, even using a microcatheter, we can have serious complications. So that's the reason we should advance the microcatheter very distal. And how can we confirm that? We can confirm using cone beam CT. We see air in the rectum. So this artery is an anastomosis to the rectum, and this one is an anastomosis to the bladder. So we should pass, we must to pass all these branches to avoid complications. Nobody wants a rectal ischemia, rectal necrosis, or a bladder necrosis. And here you can see this prostate. We can see here a symmetric prostate. This right side is bigger than the left side, and we can confirm that use cone beam CT. Left side is smaller than right side. So cone beam CT is very useful with that. So the technique that we have used is, and we have changed. Now we are injecting vasodilator, nitro or mononitrate or ivosirbide for every patient. Once we get into the inferior vesical artery to avoid the spasm, to avoid dissection, and to avoid occlusion of the artery, and to get an easier procedure and to navigate our microcatheter, we should use that. And also use that before embolic agent to open the vessels, the prostate vessels, and get embolization. We have used trisacral microspheres, embospheres, 300 to 500 for every patient. We have selected two different, and we have gotten two different studies concerning the size of the prostates, and we have seen that 300 to 500 embospheres are the best one. And we need to embolize very slow, very, very slow. It's not a fast procedure, it's not an easy procedure, but we can make easier using good technique. And we use stasis, total stasis, as our endpoint. So here is the perfect positioning of the microcatheter. We should put it a little bit back, put it here before embolization, because if we put here, I was answering this morning to some physicians, if we place the catheter here, we can get an occlusion of the other vessel. So avoid, in the beginning, going too distal with the microcatheter to avoid complication, to avoid dissection, and to avoid clot formation into the other vessels. And stasis, total stasis as endpoint. We want fully devascularization of the prostatic gland to get very good results. We need fully devascularization of the prostate to have a procedure that can be compared to other very good treatments like TURP and laser and even open prostatectomy. But for that, we need to improve our results and our technique. So after getting this artery embolized, we should move and we should look for other branches that could be feeding the prostate. If we have any other branch, we should catheterize and embolize this branch. Again, we are looking for ischemia, prostate coagulative necrosis, and reduction in the prostate size. How we can get that? We can get that trying to occlude every prostatic branch. After procedure, we have used closure devices, and patients usually go home 2 hours after the procedure. It's an outpatient procedure. We give medication. We give Tylenol, codeine, and non-anti-inflammatory steroids. And we also give laxative medication for then natural medications for obstipation, and omeprazole and ciprofloxacin for every patient for 1 week. Our results, we have observed 92% of success. Technical success for us means bilateral embolization. We know that it works, this procedure works with unilateral embolization. But again, once we are looking for long-term good results, in our opinion, we should embolize bilateral. Otherwise, we can get more revascularizations and failure, later failure. So that's why we consider unilateral embolization as a failure. And according to our results, in one patient, it was impossible to catheterize both arteries. Even neither the left side or the right side were impossible. We were not able. It was a totally failure. But in 7%, we embolized just unilateral. But remember, 92% of success, technical success. But what about clinical success? 97%. And remember, all these results, they are not from the interventional radiology department results. They come from University of São Paulo urology department. These results are controlled. They are screwed by urologists. That's why we can come here and we can say, even if my urologist come here, or I, as an interventional radiologist, I come here, this is the University of São Paulo results. We got 3 failures. And 3 failures, one of them possible to catheterize, as I said, and 2 were in patients with acute urinary retention, that we were not able to remove the Foley catheter. And what about the size of these 2 failures? One patient got 5% reductions after 2 embolizations. And the other one, 12.7, 13% reduction after 2 prostate embolizations. We were not able to remove the catheter, and both patients were submitted to surgery, TURP. But let's move concerning our results. What about symptoms? We have observed 97% increasement in symptoms. They are much better. They reduced from below 8, that means mild symptoms or no symptoms, and 2% of them were with moderate symptoms. Quality of life, 96% of these patients. You see that we have more than 5 years of follow-up in our 2 initial patients. One of them just died due to a stroke, and the second patient is still alive. So quality of life improved a lot. Recurrence. What means recurrence? Recurrence means patients that were doing bad, they got much better after treatment, but they restart to feel to get symptoms. They were feeling worse than after treatment. So we called recurrence, and we have observed 14% of recurrence. And 3% of this recurrence were in patients with unilateral embolization. And 11% were in patients with a bilateral embolization. But we could check that 2% of these 11 had the trusor hypocontractility. That means bladder is not working well. And another 2% were in patients with 30 grams prostate. That means that, in our opinion, 30 grams, 40 grams are not very good candidates for this procedure. What about PSA? We have observed 24 hours after procedure an increasement of the PSA level. And during follow-up, they were close to 50% reduced concern related to the baseline. So there is a reduction in the PSA during follow-up, and men are very concerned about that, and we need to follow PSA. Peak urinary flow, that is Qmax, improved in 74% and were stable in 26%. If we compare to surgery, peak urinary flow is the result that improves less compared to surgery. Of course, surgery makes a hole in the prostate, so patients void much better. But we are not looking for just peak urinary flow. We are looking for symptoms and quality of life, and also peak urinary flow, that we have 2/3 of our patients got this improvement. MRI is very important before and after. 100% of our patients do this procedure with MRI. We can follow all these ischemic areas. It's beautiful ischemic areas. So we can follow with MRI. Concerning prostate reduction, I can tell you that more than 50% of our patients had a reduction between 25 and 50% of the gland. More than 50%, 8%, and less than 25% in the reduction, close to 40% of our patients. We also have observed what happens to the gland in 2 patients that we got failure. And those patients, after prostate embolization failure, they went to surgery. And we saw that was a ischemic necrosis tissue in some patients with inflammatory reaction. And the post-embolization syndrome is dysuria, polacturia, urgency and emergency, pelvic pain related to prostate, constipation, and low fever. Complications, very important. We got one patient with, it's just incidental, just looking in the MRI, pubic bone ischemia, transient hematospermia, 5%, urodynamic tract infection, 4% related, urinary tract infection, 4% related to urodynamic studies that we use for every patient, and 1 related to the Foley placement. Yes. Okay, no problem. Reduce ejaculation and blood in the stool. Here is the bladder ischemia that disappeared during follow-up, and here's ulceration. So in conclusion, I can tell you this procedure is feasible, safe, and effective, with no complication rates, but there is a potential for severe complications, with good technical and clinical results. Thank you very much.